So we'll now turn to our question and answer portion of the presentation. And if you haven't already, please feel free to submit your questions in the chat and we'll go ahead. I'll start with one question that came up, and Dr. Monach, we've heard Elizabeth and Vicki mention how they have dealt with pain, but there is a question about many patients with fibromyalgia have severe pain, and if you have any other comments to present in terms of treating pain.
Yeah, I think most of the studies that are done in fibromyalgia, pain is the main outcome, and of course that's only part of function. And as both of you have mentioned, the fatigue is often the most debilitating, and that's one thing that, you know, well, you just need to get more sleep, or, you know, well, everyone feels tired. There's a difference between tired and, you know, severe fatigue. The things I put up there, both in pharmacologic and non-pharmacologic approaches, I saw people put things in the chat of, I tried this, it worked. I tried this, it really didn't work, sometimes with the same treatment, things that were not on my list. And a lot of people end up doing that. So there is no really solution to the problem of pain. I think the key things that have become clear over a period of time is that strong opioids are almost always a bad idea to start people on unless they're absolutely necessary for some other reason. And then also for your doctors to realize that you could have another source of pain. So I actually responded to someone else in the chat that is actually known from people who've studied osteoarthritis and rheumatoid arthritis, that patients who have those conditions will describe more pain if they also have fibromyalgia than people who don't. And actually, it's hard to sort of be in remission for rheumatoid arthritis if you have severe fibromyalgia, because you always say your overall quality of life is, you know, at most 7 on a scale of 0 to 10. And the level of pain will always be higher. And that makes sense, but until it was actually shown by research, it wasn't known. So I think that we don't want to overtreat people by saying we're going to get rid of all of your pain, but look for other causes. Just like I said with the shoulder injection, if somebody needs it. So some people, non-steroidals, ibuprofen, naproxen might not help for fibromyalgia, but it might help with some other part of you that is sore, and that might help you get slightly better sleep and help with the fibromyalgia. So I don't know if that answered the question or not, but I'd say the multimodal approach, what we probably really need in this country is for a lot more places to have multidisciplinary groups that have that say this is a patient, like sort of meeting together, this patient needs these specialties, and they need, this person needs to be a TENS unit, this person needs supervised exercise, this person needs cognitive behavioral therapy, this person doesn't need exercise, things like that. And we at this point aren't equipped to do it, but that's what's really needed, I think.
And so needed for patients with ME, CFS. I know our group has talked a lot about our hopes of someday having a multidisciplinary clinical center to provide care. There is a question about a blood test that has been proposed for helping to diagnose fibromyalgia that seems to be available, and there's a question in terms of whether you've heard of this, Paul, or do you have an opinion?
The only way in which I have heard of a blood test being done was a patient at the VA who brought me his genetic risk score. So I don't know if that is what is intended or not. A genetic risk score is merely what it is, but that's actually true for a lot of tests we have. Nothing is perfect. And more importantly, clinically, that's what he had. Although interestingly, he'd been treated for many years as having psoriatic arthritis because he had psoriasis. And he's like, none of the drugs work. All that stuff that shows, Phil Mickelson winning majors didn't help me at all. And that's because that really wasn't the source of his pain. So that kind of thing, genetic risk scores are probably going to make their way into clinical medicine, if that's what we're talking about, eventually, but they're always going to be relatively small changes. And so they're more helpful when you're not sure diagnostically, or if they identify subsets to say, okay, this is somebody who also has something else, and we should take a different approach of sort of dividing up the syndrome into its different causes that you would treat differently. I'm not aware of any other blood tests, but like I said, this isn't an area of my specialty. So interesting that I put in Dan Claus, the leader within US Rheumatology, and that both of you have actually encountered him separately, but definitely his articles and one of the other ones I put in there are really the highest quality summaries for clinicians that I know. So it's good to know also he's involved in the communication with patients as well.
But somebody added in the chat that there's an immune profile test showing that there's a characteristic profile in fibromyalgia.
Okay, yeah, I'm not aware of it, and I'm not sure. Just thinking as a scientist what the control group was, but I wouldn't be surprised. I mean, these are and it takes a long time for things to get from like the bench to research to actual clinical use, especially for all the research that's been done with sort of panels and what are called biomarkers that aren't just one blood test. It hasn't made its way into clinical practice because it's not the way laboratory medicine has traditionally done things. We need to get there.
There's also a question, Dr. Monach, whether fibromyalgia can occur in children.
Yeah, absolutely. And so it is sort of a saying, and I don't actually mean this in the way I said of doctors being dismissive of it. Among pediatric rheumatologists, it's more of a commentary on how little pain sometimes juvenile rheumatoid arthritis causes in kids, that parents will just notice their kid like can't get out of the car, it's limping down the stairs, something like that. They said if a young person is sent to a pediatric rheumatologist primarily for pain, it's more likely to be fibromyalgia. There is an association with hypermobility, just as Vicky mentioned. There's no question an association both early in life, onset early in life, and also later in life. How much it predisposes to early osteoarthritis, that's more of an unknown. Is it a mimic of fibromyalgia? Is it a risk factor for fibromyalgia? Well, if it's pure hypermobility that is causing stretching of joints, that shouldn't cause fatigue as well. So, but there's definitely an association with people sort of meeting the overall picture of fibromyalgia and joint hypermobility, whether it's EDS or doesn't have a gene associated with it. But yeah, and that is often something that is seen in pediatric population as well. I don't know how common it is, but it's not as common as in adult rheumatology, but they still a pediatric rheumatology practice of the new referrals coming in, a sizable percentage would have joint hypermobility or fibromyalgia as the sort of diagnosis of choice. It's just, it hasn't been studied as much as kids, and so people are a little more reluctant to use the term.
Thank you. And one final question, this era of COVID, do you think studies from long COVID or ME/CFS could be relevant to fibromyalgia as well?
Yeah, I mean, definitely when you see differences between CFS, and fibromyalgia, you wonder if there's sort of a study bias. So definitely there's been more study of the immune system and of inflammation and in ME, but to the extent that there has been study in fibromyalgia, it hasn't been as consistent or dramatic of findings. And I do think that the issue with exercise, I've had patients with fibromyalgia who say, I can't tolerate exercise. And I wonder how many times have I sort of missed it. I don't push people to do things they can't do, but I have heard more than it hurts while I do it, that's why I couldn't increase my exercise, versus if I exercise, I can't function for a day. Okay, that's not something I was ever taught in medical school. It's familiar to all of you. So that was eye-opening to me, and sort of how many times have I missed this in patients I was seeing for fibromyalgia. Sorry, so in terms of the different studies being done, I think they're definitely, we have too many silos, and the multidisciplinary approach would be if it's linked to research, would be a way of looking at these different conditions sort of as either those overlapping Venn diagrams that I couldn't draw, or as a continuum. And if of trying to put some rationality behind, is it inflammatory or isn't? Well, probably is in some people and not in others. And how do you pick apart what's important in different people? But I think the different research techniques that have proved to be valuable in one condition should probably be looked at in other conditions to see if the same findings are made, if that makes sense. That's sort of low-hanging fruit.
Thank you. Well, we know you're giving a grand round soon, Dr. Monach, and we would appreciate you making the distinction about exercise in people with fibromyalgia and ME/CFS and who may have comorbidities. We're trying to make the providers more aware of that in terms of the dangers of doing exercise in that group. Well, thank you so much, Elizabeth and Vicki and Dr. Monach. This has just been great. We really appreciate it. The recording of this session will be posted on the Mass ME/CFS YouTube channel in a few days, so watch for your email about that. The topic for our Sunday conversation in June is a whole person health approach to myalgic encephalomyelitis, chronic fatigue syndrome, lessons for post-COVID conditions. The date is June 19th at 4 p.m. Eastern Time, and the featured speaker is Dr. Maria Vera Nunes, who has been specializing in the treatment of people living with ME/CFS for more than 20 years, and who originally worked with Dr. Nancy Klimas at Nova Southeastern University Institute for Neuroimmune Medicine for 7 years. This program is being presented jointly with the New Jersey ME/CFS Association, so please join us. And if you have any ideas for future programs or speakers, please email events@massmecfs.org. Sunday Conversations is not intended to be a series of research presentations, but rather programs that will provide a variety of practical information that patients and families both need and want. And if you'd like to join the Sunday Conversation team, please email volunteer@massmecfs.org. We're working on the fall schedule now, so please let us know. And finally, if you have found this program worthwhile, there are a few ways you can help. You can make a donation to help support this series by donating online at massmecfs.org/donate. And on the same page, you can sign up for our newsletter. And if you donate $25 or more and check the Become a Member option, that will establish or renew your membership, and you will be invited to our members only programs. Thank you all for coming, and we hope to see you again next month.